again, we're going to start out with the administrative medical assistant. This week we are doing chapters 10 and 11. So 10 is scheduling appointments and patient processing, and chapter 11 is daily operations in the ambulatory care setting, which will coincide with a physician's office as well. So we will be doing those two chapters. I have checked with adult ed as well as Amy, and there will be no classes next week. The schools are closed because of the holidays. So you have an extra week off, and then we will resume the week after Thanksgiving, and we'll start that week with chapter 12. So again, we're going to start out with chapter 10, which is scheduling appointments and patient processing. Again, you've got your vocabulary on 146, and on 147, when we schedule, we want to make sure that the schedules are set up according to how the provider likes them. Most providers will allow, for example, a certain number of new patients per day because of the time that's involved with a new patient. Some physicians with main care will only see one main care patient a day because the amount of money that is reimbursed. So the provider's time as well as the patient's time is very valuable, so we want to make sure we allot the appropriate amount of time for the appointments according to the providers. So we want to develop a schedule meeting the provider's needs and the patient's needs. And most of the time, unless you're walking into a practice that is just opening, this is probably going to already be set up. There's always room for tweaking. Our schedule, we try to stick to it, but we're a specialty practice, so sometimes we have to allot for emergencies. Broken bones tend to happen periodically, so it's good, and we'll talk about leaving times for emergency slots as well. So again, we'll go over learning to schedule the pros and cons of various practice management appointment scheduling, telephone scheduling versus scheduling patients right in front of you, new patients versus established patients, and how the medical assistant can also handle other types of scheduling appointments. So establishing the appointment schedule, again, we want to have parameters that our physicians are comfortable with. So, for example, demographics of the patients being served, where are they located, what type of patients are they. Some offices will have one evening a week or possibly a Saturday morning available for patients who may work far away, may not be able to get to the physician's office if you're open regular, like 8 to 5 during the week. So again, having your provider be aware of that may be a possibility. Provider preferences. Does a provider become restless if the reception room is not packed with patients? Does a provider worry if one patient is kept waiting? Is the provider habitually late? Does the provider move easily from one patient to another? Do they require break time? If you're going to start the provider at 8 in the morning and send him through till 5 at night, when are you going to give him a break? Or does he go non-stop with patients? You also have to take into consideration your staff, because if the doctor's not taking a break, the staff's not taking a break. So that can cause a problem. Would the provider rather see fewer patients and spend more time with each patient, or would he rather see as many patients as he can, and maybe they don't need an extended period of time? All of these become an integral part of the scheduling process. The provider also has telephone calls to make or receive. Also, he has to dictate. He may have meetings to attend. He may have mail to take care of. So that has to be allotted throughout his schedule as well. Again, next, the office hours and the length of appointments need to be determined. So set up a shortest period of time. What is the least amount of time that he can see a patient? Most providers, you'll find, and schedule books typically are 15 minutes. If that's comfortable for your provider, then typically, if they're routine follow-up visits, that's for an hour. Maybe they only want 3 an hour with a 15-minute catch-up to do the dictation, or if he or she should fall behind, anything like that. Creating the appointment matrix, so setting that block schedule up. Most of your practice management systems allow you to set the schedules. You can have a different schedule for each day. You can have a Monday schedule. Maybe Monday's going to be all follow-ups. On a Tuesday, maybe you have new patients in the morning, post-op in the afternoon. Wednesday's a surgical day. You can block matrix these schedules so that they are set up for your provider. Again, follow-up or recheck appointments typically are less time-consuming, so 10 to 15 minutes, again, depending on the provider, whereas a new patient or a comprehensive patient may be 30 to 45 minutes, so you need to allot that in their schedule for time as well. Excuse me. For a complete physical exam, for example, it might be scheduled for 30 minutes, but the provider might routinely spend 45 minutes for that complete physical. So if it's scheduled as 30 and he spends 45, you're already bumping his schedule and he's making himself late for the other patients that are already scheduled. And a lot of it is trial and error. If you look on page 148, this is just showing you, this is SIM chart, and it's showing you an example of a schedule, Sunday to Saturday. It's broken up by time, and it can be broken down by, here they've put the lunches in, hospital rounds, so they give him time or her time in the morning to go to the hospital and make their rounds. Some of your providers, they don't typically wear a watch, so they really don't know how long they've been in the room, and most practices will not put a clock in the exam rooms because therefore your patients aren't watching the clock. So if you find your provider is being a little bit more lengthy, then sometimes the medical assistant can either buzz the room and remind him, time is up, so to speak, or a lot of times providers will wear pagers, and you could page them, and that's a sign that their time is up for the appointment and they can move on from there, especially if the medical assistant or a scribe is not in the room with them. Another thing to keep in mind when they're scheduling appointments is the availability of facilities. So if they're scheduling surgery, what are their allotted times for surgery? Can they only do surgery in the morning at Hospital A? And then do they have a capability to go to Hospital B in the afternoon? That all has to be taken into consideration. Also, if you have more than one provider in the practice, but you only have one room to schedule procedures in and both providers are doing procedures, you need to allot enough time so you have time to flip that room so it's available for the next provider. EKG is the same thing. You don't want to book 2 at the same time if you only have one EKG machine. That's not going to happen. So if it's a 15-minute appointment, then that's how it should be scheduled with enough time so that you can, again, flip the room and get it ready for the next patient. Methods of scheduling appointments. The two most common methods of scheduling are computerized and appointment book, or paper is what we call it. The computerized is your practice management system. Pretty much pretty basic. Again, you can set up the length of the appointments. You can code the appointments, like for example, FU for follow-up appointment, NP for new patient, CON for consult, second opinion. You can pretty much do it however you want. And again, you can have different schedules for each particular day that you want. Another advantage for computerized scheduling is to see future appointments. So when a patient calls inquiring about appointment, you type in their name, it pulls up their appointment, and then you can also search for future appointments. Multiple users can access the appointment schedules at the same time. That way they are not waiting. If you schedule by a book, it's one book. So if there are two people scheduling in your office and one has the book, the other one's going to have to wait until they are done before they can schedule with the paper version. With the computerized, you still should always have a hard copy. So typically you print out the night before their schedule so that they have an idea what's going to happen. That works well for us, especially 2 weeks ago with the storm that we had. We printed out our schedules Friday before we left the office, and Monday, of course, nobody had power, so we could not go in, but we could go in and access the schedules enough to make phone calls via our cell phones to let the patients know not to come in. We had no electricity and we were not able to see patients. If it's appointment book scheduling, so the paper copy version, office stores have different types, week at a glance, month at a glance. It's completely up to you. Some of them are color-coded. Wednesdays can be color-coded yellow, for example, for a follow-up, or so that you know if you're on a yellow, it's always a Wednesday if the patient should ask for a Wednesday. If you look at the bottom of page 150, this is an example of a color-coded appointment scheduling book. A good thing to have is backup, because computers can crash, and if they crash, we need to have something that we can resort back to if we need to. Self-scheduling, I'm not one for self-scheduling because our schedule is such, the doctor is very formatted how he wants, how many patients, and for new patients, follow-up and such, that if we had patients trying to schedule their own appointments online, I think it would confuse more of our patients and we'd have more scheduling errors than not. But it is an availability for some big practices for self-scheduling. On 150, the legality of the appointment scheduling system, they have to be accurate. It can be used as a legal record. Missed appointments do need to be noted in the medical record. So if an appointment is missed and you're using a book method, it still needs to be noted in the patient chart, because otherwise all you have is the book. If you're using an electronic form of the scheduling, that has a tracking, so you will always be able to see those appointments that have been canceled or rescheduled by the patient. If you're using a paper version of a book, typically pencil is used so it can be changed easily. Be careful if you are doing that. Pencil can also be erased very easily. So you could erase an appointment that may not have been intended to been erased. Patient's name and phone number in the scheduling book, so that if you need to reschedule appointments, you have the phone number to call them without pulling the chart. Appointment book should be kept for the state statute of limitations. Then it can be shredded for privacy purposes. So with this being said, typically those paper versions of your scheduling books, the state statute for medical records or billing records is typically 7 to 10 years. So at the end of the year, you just can't throw that book away. That book still needs to be maintained. Computerized scheduling can also still be used in legal performings, and computerized, again, can track missed appointments, rescheduled appointments, anything like that. Type of appointment scheduling, on page 151, we have time-specific or stream scheduling, and that is when they tell you to be there at 4 o'clock for your appointment time is 4 o'clock, plain and simple. Wave scheduling is a little bit, offers a little bit of flexibility each hour. Wave scheduling assumes that the actual time needed for all the patients will average out over the course of the day. So instead of scheduling patients at each 15-minute interval, it places 3 patients in the office at the same time, and they're seen in order in which they arrive. Some providers may like wave scheduling, others may not. It depends on whether or not your patients need to arrive early for paperwork. There's a whole bunch of different factors that can play. Modified wave scheduling. This is when you have 2 patients to come in at 10 o'clock and a third at 10:30, and that's repeated throughout the day. So again, that gives them a little bit flexibility to catch up if they need to. But again, you want to make sure that by doing that, if you schedule 2 patients at 10 o'clock and then one at 10:30, and you're taking your second patient in at 10:30, and your third patient was scheduled at 10:30, now that third patient is having to wait either another 15 minutes to a half an hour, and then the whole schedule kind of goes domino from there. Double booking, self-explanatory, booking 2 patients at the same time. Open office hours. Typically, this would not happen in a regular physician's office, more or less urgent care facility setting. ER would be a good example of that. Open office hours, you're seeing when you walk in with that emergency. Open office hours can have many disadvantages. It can be crowded, long wait time. It can just make for a miserable time, especially if you're not feeling well and you're going to end up sitting and waiting. Grouping procedures. So grouping or categorizing procedures is another way. So an internist might reserve all morning appointments for complete physicals, or a pediatrician might do all morning for well baby checks or immunizations or something along that line. Surgeon, 1 day each week for seeing only referral patients. That may work. It depends on how many people you get referred from other providers' offices. If they don't refer to you very often because of your specialty, that might work. It may not work for all specialties. Advanced booking. Often appointments are made months in advance. All appointments, if you give the patient an appointment card, it should say on it that patients need to give a 24-hour notice. If the 24-hour notice is not given, there can be fees involved for rescheduling at the last minute because you've reserved that slot for that patient, and now typically if it's less than 24 hours, you really can't fill that unless you have an emergency come up that you can work the patient in. Time patterns. When booking appointments, make it a policy to leave some open time. So if a patient calls, for example, the emergencies, you have that availability. Typically, Monday after the weekend, you get slammed, and Friday before the weekend, everybody wants their prescriptions filled or they're going out of town. So those tend to be the 2 worst days Just, maybe giving the physician an extra half an hour somewhere throughout those days may enable that catch-up slot. On page 152, telephone scheduling, obviously pleasant manner, willingness to help the patients, be considerate if the time requested is refused. Some patients, when they don't feel good, they want to get seen right away. You may not be able to accommodate that, but let's do our best, comply with their request as much as you can. Many offices will offer the patients a choice. So you may say, well, we have today at 4 o'clock, or we could see you Wednesday morning at 9 a.m., which would work best for you. And by giving them an option, it makes it a little easier for the patients, and typically they will pick one or the other. Always repeat the time to reinforce the appointment. Again, that's pretty straightforward. You want to make sure that they document the time correctly. If you are using an appointment book, make sure you are writing legible. You want to make sure that when you are preparing charts for that day, you can read who the patient is, because you're going to need to be able to get that chart ready and prepare it for the next day. If I start coughing, I apologize ahead of time. I just went to the doctor, so I have pneumonia, so I haven't started my medicine. I have to pick it up tonight. So if I have a coughing fit, I apologize. And of course, because I said that. Sometimes you are going to need to schedule appointments for new patients. So again, new patients require more time than follow-up patients. We also need more information because we've not seen them before. Now, you may not be able to get all that information in the scheduling book depending on the slots, but we need some pertinent information. You need your patient name, you need their date of birth, their phone number, and typically we need their insurance, because we need to find out if they require a referral or an authorization. Otherwise, it's possible that that visit is not going to be paid for. Again, even when scheduling new patients, give them an option. So give them 2 dates, 2 times. With new patients, there typically is paperwork that they have to fill out ahead of time. A couple of different ways you can do that. If the appointment is being scheduled far enough out, you can offer to send them the paperwork, have them fill it out and bring it back with them. If that is not an option, some offices, you can actually send them a link to your patient portal and they can fill out the paperwork right online, and then you download it right into their electronic medical record. Or you have them arrive early for the appointment. Some say 15 minutes early. I would say between 15 and 30, depending on the paperwork that needs to be filled out. If it's a lengthy form with health history, it may be more towards the 30-minute than the 15-minute slot. And again, when you are giving them a time, make sure to repeat the appointment date and time, and thank them for calling. Some healthcare facilities will mail out those packets or the information to the patients. It will have the paperwork that they need to fill out. It may have a brochure describing the practice, where you're located, giving some information about the providers with your phone numbers, staff name, what services you offer, hours of operation, and how to schedule appointments. Again, this is all depending on the practice preference. Some practices do have these brochures. Others, if they're very small practices and not linked to a hospital, they may not have one. In addition to the brochure, you should include a health history form and the notice of privacy practices. The privacy practices, again, goes over letting the patients know who has access to their records, that you will not give out information without your patient's authorization, everything like that. There is the notice of privacy practices does need to be posted in the office as well. Your patients do not need to take a copy of it, but it does need to be available for them should they request to read what that privacy policy is. And again, then with scheduling, by knowing their insurance, the medical assistant may need to conduct pre-authorization or pre-certification, or possibly even check and make sure with that insurance that you are eligible. Because again, if a patient is not eligible, nothing is going to be paid for. On page 154, again, you can see this is the SIM chart, so another schedule. But at 8 a.m., you have an Isabella with Dr. Martin for checkup. 9 a.m., well child check. And then 10:30, check blood pressure. Lunch at noon. And then at 1 o'clock, an annual exam. So he, according to that, looks like he still has some openings throughout the day. But again, you can tell that a blood pressure check is a narrow blue stretch. So that's probably like a 10 to 15 minute exam, whereas the 8 o'clock and 9 o'clock might be a 30-minute for a follow-up. Again, depending on the doctors. Established patient, typically these appointments are scheduled when the patients are leaving the office. So they've come in, they've seen your provider, and now they need a 6-week follow-up. So again, these appointments are typically done before they leave, so you can verify the phone number. You can check the information if you need. Always, if they are in front of you and you are booking an appointment, give them a appointment card. Some of them may use their phones and not want one, but they will clearly tell you. And again, do the same thing if they're in front of you versus scheduling on the phone as a new patient. Give them options. So if they want to come back in 6 weeks, what day is good for you, morning or afternoon, and give them a couple of options. If you look on 156, again, you can see another version of the scheduling. The lunch and staff meetings are in pink, and then the schedules themselves are in blue. And this is for nurse practitioner as well as the provider on different days. So you can see that over in the left, patient visit is blue. A block, which means like a lunch or meeting, would be pink. And then you can designate green as another color. So if they had to maybe do a deposition or something like that, you could use green for that. Again, scheduling by telephone. We should have the patient address, telephone number, and the insurance should always be verified so we have the most current information. If we don't have the current phone number and we need to call to cancel, that's going to cause a problem because we're not going to be able to reach them. They're going to show up in that time slot and the doctor's not going to be there to see them. Scheduling the other types of appointments. This can be surgeries at the hospital or other facilities, consultations, meetings, house calls, nursing home visits, treatments at other facilities. If the provider needs to go make rounds on their patients in the hospital, we can also schedule those type of appointments. Like a couple pages back up at the top, it said hospital rounds first thing in the morning. That would be the same similar thing. Again, if you're scheduling with facilities, you need to provide them patient name, address, phone number, sometimes a social security number, or at least the date of birth so that they can make sure they have the correct patient. And again, the insurance information so that they know whether or not they need to request authorization. Sometimes patients' allergies, if they are being admitted so that's a heads up. If they are being admitted, sometimes before the hospital will actually say send them over, you need to give them an admitting diagnosis. So that's something we need to make sure we obtain from our provider. Some offices will ask for a picture ID so that they can verify it's you to make sure that you're not using somebody else's insurance. Inpatient surgeries, call the facility where the procedure will be performed, give them all necessary information. Sometimes that facility is going to require that the patient have blood work done or possibly an appointment with the hospital to go over their past medical record or past medical history, especially if they have a history that needs attention for anesthesia or something along that line. Outpatient and inpatient procedure appointments, you may be asked to arrange lab or x-ray appointments. Same thing, when you call the hospital to schedule a x-ray, you need to provide them the basic information: name, demographics, date of birth, phone number, and insurance information. A lot of outpatient testing is done at the hospitals because the physician's offices do not have the capability to do a lot of in-depth lab testing or anything more than a basic x-ray. Some patients will require a series of appointments, so like weekly intervals. For us, that's our physical therapy. So if they need weekly appointments, sometimes they like to have it the same day of the week and the same time. If it is often the medical assistant's responsibility to give the patient any special instructions for the procedure or the test that is going to be performed, as well, not only just verbally, but possibly written. Patient undergoing general anesthesia typically needs to fast for 12 hours prior to the procedure. If they take medicine, depending on what the medicine is, some medicines can be taken with just a small sip of water. Other medicines, they will want them to hold and then take after the procedure. So when you are scheduling, that is when they may ask certain information like that and then advise you to let the patients know about the fasting and or the medication. On page 159, outside visits. So again, this would be if the provider regularly makes house calls. Skilled nursing facilities, you would want to block out if he goes there once a week on Wednesdays, maybe at 11 o'clock before lunch. You want to make sure to block that out. If you are scheduling appointments where another provider drops into the facility to see the provider, your provider. If we have a pharmaceutical rep, it used to be that pharmaceutical reps would come by, they would bring samples of medications pertinent to your doctor's specialty, they would bring goodies, they would bring lunch. Some providers don't like that. It's distracting, and during their lunchtime, they need that time to finish up on their notes or sign off on their labs or x-rays, whatever it happens to be. So the medical assistant may need to screen pharmaceutical reps to see which ones the doctors may really benefit from seeing, what they have to offer with regards to medications pertinent to their specialty. And sometimes it's preparing a list, and then you can ask your providers which ones they want to see should they happen to stop in the office. Salespeople, unsolicited salespeople from medical or surgical equipment companies. Your doctors may not be the ones that deal with that. You might have somebody in your office that takes care of ordering medical supplies or office supplies, and maybe they deal with that person. Maybe it's the practice manager. So again, that sometimes can present a problem. Also, we can have problems if we have late patients, habitually late. Again, sometimes we will tell our patients to come in early, especially if we know they have to have paperwork filled out, or if we know that usually they don't always show up on time. We may tell them to be there 10 to 15 minutes early, and then hopefully they walk in at the time they need to be there. Rescheduling appointments, changes sometimes need to be made in the appointment schedule. So when you reschedule an appointment, you need to make sure the first appointment is removed from the appointment book, then set the new appointment. Otherwise, if you don't erase it, it's going to look like your patient should be there on 2 days. And then it's a little bit harder to figure out which one should be there because you don't have any way of knowing what day you scheduled those appointments. Maybe you scheduled one on Monday and one on Thursday, and obviously we want the Thursday appointment. The Monday one was the canceled, but we really don't have an easy way to do that. Emergency or urgent calls will sometimes come into the office. Usually the medical assistant will go through a screening process to determine the urgency of that appointment and how urgent it needs to be seen, whether it needs to be seen that day, whether it's something that shouldn't even be in your office and they need to go to the hospital, to the emergency department. Emergencies can involve emotional crises in addition to the more obvious physical problem. So those who are actually ill should be seen the same day. And obviously, if they're worried that something is going on and you know their health history, typically they know when they don't feel good, and you will be able to sense those patients that need to be seen. If you do have a life-threatening emergency, somebody's calling in, keep that patient on the phone until you know that the ambulance or the EMTs or paramedics have shown up and told you that they are there, and they will tell you, you're fine, you can hang up now. Make sure you always stay on hold until that happens. The name, phone number, and location of where that call came from. So God forbid, but if you should get disconnected, even though it may have been Mary Smith calling, Mary Smith may not have been at her home. So it's not just as easy as looking up Mary's address because she may have been somewhere else. So trying to get that information while you're talking to them until the paramedics arrive. Provider referrals. If another provider telephones, request a patient be seen on the same day. Most of the time your providers will do that. But again, you've got to see how your schedule will accommodate that. So does your provider leave a slot at the end of the day just in case you have those work-ins? Patients without appointments. We should have a policy for patients without appointments, or what we call walk-in. If your patient doesn't need immediate care, then an appointment should be scheduled for them. Just because they walk in and say that their knee hurts doesn't mean you need to see them that day. There should be a process to determine whether or not the patient's illness or injury requires immediate attention. Failed appointments. Most practices have either somebody in their office that does phone call reminders of appointments, or an automated call stating when their appointment is, the date and time. If that is in place, it will allow the patient to press a button to confirm the appointment, or press a button if they need to reschedule the appointment. If they're getting a call about the appointment and they've confirmed it and then they do not show up, we know they've gotten that notification. So then we go into our no-show or failed appointment policies. Every office should have one. Typically, if you reschedule an appointment, and it's beyond 24 hours from the appointment time, there usually is not an issue. That's okay. You can reschedule them. If they are canceling the appointment within a 24-hour period and it's an habitual thing, we may not have the availability to reschedule and put somebody else in that slot. So therefore, we've just lost that scheduling slot for that provider. So in your brochure or practice information, you need to have a policy set in place for that. If patients are scheduled within 24 hours, what the penalty is or what the procedure is, for example. Have a specific policy on no-shows and adhere to it. Some offices, the first no-show is a warning. The second no-show, some offices may give them a second warning. Other offices charge on that second visit $30 because, again, you can't fill that slot. And then if they do it again, they have a third no-show, so they've paid that fee. You reschedule them, and they don't come in for that one. Now that's $60. But again, practice, preference. I will tell you, if you set a fee and they no-show, they will pay it if they want to come back in. And usually we don't have a problem. They pay it once and they typically will not no-show again. Sometimes it happens, but the majority of time, especially if they know that amount is going to double, the second time they don't keep their appointment. How can you increase your appointment show rate? Meaning making sure the patients come in for their appointment. Well, you can't hold them by the hand and physically walk them into the office, but you can have the automated call system. Again, that sends messages to the patient, a reminder of the date and time of the appointment, and giving them the option, again, to confirm the appointment, to reschedule the appointment. Appointment cards work really well with patients. Again, typically these are on your follow-up patients, so when they check out and you're scheduling them, you can give them an appointment card. Not so easy to do if you're scheduling over the phone unless you are mailing them information. The confirmation calls, again, very similar to the automated call routing. This is so-and-so at Dr. Smith's office confirming your appointment Friday at 8 a.m. Again, some people still do the regular calls from somebody in the office, and others are automated. Send your patients an email reminder. If they provide you an email address, you can send email. You can also mail letters or reminder cards in the mail as well, depending on how far out the appointment is. How do we handle cancellations and delays when your patient cancels? We should have a list of maybe people that's on a cancellation list so that if somebody cancels, we can always try to fill that slot with somebody who really wanted to get in sooner. So again, keeping a list, and this can be electronic through your practice management system or paper version. Again, the cancellations should be noted in the medical record as well with a reason for the cancellation. So you could put today's date, patient canceled, feeling better, or due to death in the family, whatever it happens to be, but document that so you know why that appointment was canceled. When your provider is delayed, so let's say they did surgery this morning, and they're coming into the office this afternoon, but they're running behind. Depending on how far behind they're going to be running, sometimes it's nice to give your patients a courtesy call and give them the option. Do they want to come in and wait, and they will be seen as soon as he gets in, or do they wish to reschedule? Show concern for the patient, but don't overly apologize. Things come up for providers, they're doctors. Emergencies happen. When the provider is called out for an emergency, again, same type of thing. Act quickly. call the patient scheduled for a later hour. Some may end up canceling a whole day. Obstetricians or surgeons with emergency surgery, whatever it happens to be. The quicker you act, the quicker you can get a hold of those patients. And sometimes it's breaking up the schedule. So Mary does the morning and Joni does the afternoon. Then you're not duplicate calling. Somebody's working on the morning, somebody's got the afternoon. If you look on page 162, again, these are just examples of little appointment cards. Some of them have stickies, so you can stick the appointment on your calendar. Some are magnets, so you can put them on your refrigerator, whatever it happens to be. We also have when your provider is out of town. So when your provider is out of town, we need to do the same thing. We need to, whether it's personal or they got delayed coming back from a trip, we need to call patients, let them know. We don't need to give them the actual reason. We can just say the provider is out sick today, the provider has been delayed out of town. You don't have to tell them why, but your appointment needs to be rescheduled. On page 163, patient processing. So this is your reception area. So when they walk in, the reception area should be an inviting place. They need to feel comfortable. Visits to the provider can be stressful, especially if you don't feel good. So we want to try to make these patients feel a little bit more comfortable. Patients have a choice of healthcare providers. So if they walk in and they're not given a good impression by your waiting room or your staff, they have a choice. They can go somewhere else. When they have a good experience, they're more apt to tell their friends and family than if they weren't happy at all. So a first impression is a lasting one in the reception area. And again, we want to have good traffic flow in here. The seats, people say make sure your seats are comfortable in the waiting room. And they should be comfortable to an extent, but hopefully your patients aren't going to be sitting there for extended periods of time. So they don't need to be lounge chairs or fluffy, poofy chairs. Fresh, harmonious colors in the waiting room. Comfortable furniture, good lighting. Recent magazines. One of the things I hate is walking into a waiting room and having magazines from 3 years ago. There should be current magazines that the patients have access to. Some offices may have a small desk, a computer that they could go on, check the internet. Again, this depends on the individual practice. Some patients donate their magazines. Our patients, some of them do. When they're done with their magazines, they'll bring them into our office by the bag, and then we recycle those magazines throughout our waiting room and our patient exam rooms. Again, the writing desk is nice. They talk about having a telephone in the reception area. Again, whether or not that's needed. Typically, if somebody needs to make a phone call, if they do not have a cell phone, they will ask you to place a call, and then you could bring them back in a private area. So I don't know that you will see a lot of phones in the actual reception area. If the medical assistant's desk is in the reception area or in an open view of patients, anything that the patients can see should not be cluttered. It should be the minimal, what you need to complete your work. No patient charts that patients can see, that type of thing. If you take a look on 164, this is an example of a medical office. So up in the top left corner, you can see the waiting room and the check-in area with some record storage. Then right around the corner from the reception desk is where they do the vital signs to bring the patient back. And then you'll see as they walk around, there's one exam room, there's a procedure room, bathroom. In the middle is the lab supply closet, where people make reminder calls or scheduling appointments, the billing area. And on the outside walls are your exam rooms and your doctor's offices. So again, depending on how many providers you have in the office at one time, the doctor up in the far right corner may use those first two exam rooms right next to him. And then the doctor in the lower right corner might use the two exam rooms above him. So that will all be determined by which providers are in your practice. So how do we prepare for your patient arrival? Typically you do it ahead of time, not the morning of. If you prepare in advance, it helps your day go smoother. So prepare your health records. So you check your schedule. You can print it. Most people will print it. And then you go, if it's electronic health record, you just need to review that electronic health record, especially if Mary's coming in for a follow-up visit with regards to her MRI. We want to make sure that MRI is in the chart for the doctor. If you're pulling charts, so you're still paper, you're doing the same thing, but you're doing it a paper version. So make sure whatever the doctor needs for that visit is in the chart. And then you can check the patient's name off the schedule as you have checked it, so you can move on and make sure everyone is prepared throughout the day. You want to arrange those medical records sequentially in the order in which the patients are scheduled. You also, if you're using a paper version of a chart, you want to make sure on the progress note that there's enough room for the doctor to do the note for that particular visit. If you've only got an inch down at the bottom of the page, you're probably going to want to put a blank progress note sheet in there, because that's probably not enough for him to do what he needs to for that visit. The patient check-in process, this can vary. The reception desk typically greets the patients as they come in. Some may have a sign-in process that promotes privacy. Others will still use a sign-in sheet. It's incidental disclosure. But if you can take care of the patients on a one-on-one basis without having their name out so somebody can see it, it does make that much better. You want to make sure in the reception area that patients' medical records are not accessible or in view of patients. We don't want them seeing even the names on the charts. And this goes back to the Health Insurance Portability and Accountability Act by HIPAA. The medical assistant should check the reception room each time they've been away from the desk to make sure patients have arrived. Greet the patients by name. If you don't know the patient, you can, again, use a sign-in register that promotes patient privacy. Again, it's incidental disclosure. It's not a violation of HIPAA. During the patient check-in process, the medical assistant takes steps to protect the other patients in the reception area. So if you go into your primary care office, like me today, and you're sick, they typically will tell you to put a mask on so that the other patients don't get sick. Or if you know that that patient may have been traveling abroad, they may ask where and how long ago, due to the CDC, for those diseases that can be brought from other countries, because that patient may need to be isolated, may not be able to be around other patients in the waiting room. If you look on 166, this is an example of a privacy patient sign-in. So again, the patient sign in, and then that first label comes off, and you can't see the information. Sign-in sheets, basic information. Again, it's completely up to the practice. Greeting the patient, Every patient has the right to expect courteous treatment when you're in an office. So again, greet them courteous. Sometimes you may be on the phone. Let them know. Some offices will put up a sign saying, if this light is on, I'm on the phone, I'll be with you momentarily, so that they know you're on the phone and not just ignoring them. How are you doing? The doctor will be with you shortly. Anything like that to make them feel comfortable. Patient interaction. So it helps the patient feel comfortable even when the actual facility may make them feel uncomfortable. Some people do not like to go to the doctors, but if we try to do everything we can to make them feel comfortable, that's going to eliminate that other opposite feeling for them. Patients like to be acknowledged when they arrive. We may not always pronounce a name correctly. So sometimes we have to do it phonetically, and sometimes we're corrected if we pronounce it incorrectly. If we use paper charts, sometimes it doesn't hurt to put that phonetic spelling or pronunciation in their chart so that next time we have it down so that we may not pronounce it incorrectly again. Providers and staff can make notes in the health record about current events in their life. So if they've had a recent death in the family, a vacation, something like that the doctor feels he can maybe make the patient feel more at ease about bringing up that trip that they just took to Italy or something along that line. Makes them feel more comfortable. But remember to keep the patient's safety in mind and make sure that he or she has the type of support that they may need once they get home from an office visit. So if somebody came in today by themselves and they're having chest pain, but it doesn't warrant the patient being admitted, but the patient probably shouldn't be by themselves, it may mean that we need to make some arrangements with the help of the provider to make sure that when this patient gets home, she has the support she needs so that she's not by herself like the doctor recommended. Registration procedures. So on the first visit to the provider's office, there is a process. Patient information, which is usually obtained via a registration form, which has demographic information. The demographic information will be mailing address, phone number, date of birth, emergency contact. If the patient is a minor, it should be filled out by a parent with the parent's information. Typically, this registration form also will allow the patient, if they are over 18, or the parent, to sign authorizing us to not only treat the patient, but authorizing us to bill the insurance company. So it's very important that that be built in to your demographic sheet as well. And if you look on 168, that demographic sheet, again, name, date of birth, responsible party, address, phone number, contact person, sometimes place of employment, occupation, social security number, nearest relative. If the patient is being referred, we may have a slot for who sent you, that type of thing. When the completed form is returned, check it. Most offices require that the copay be paid prior to the visit. So once that patient is turning in that demographic sheet and we're scanning that insurance card, we can say, I see you have a $30 copay. Let's take care of that now. And then it's able to be done so that when the patient is done their appointment, they schedule their follow-up appointment, and then they're able to leave. They don't need to remember to try to stop at the front desk to do their copay, or if the front desk is busy, they're not going to stop and do it, and then you just did not collect that copay. And collecting the copays up front help the reduction of sending bills, which cost us money. Every time we have to send a bill to the patient, depending. It can average $10 to $15 to send a statement. So if you are sending a statement to a patient for a $5 copay, it's pointless. So collecting that copay up front. If it's a new patient, they may need to be given the NPP, the facilities NPP document, and sign it as an acknowledgement of receipt of that privacy policy. And that privacy policy, again, is added to the patient's chart. Unless that privacy policy changes, you do not need to have the patient sign a new one yearly. Some offices do, but only if there are changes, really, do you need to have them sign a new one. If nothing has changed, as long as they have signed one, that is good. Obtaining a patient's history. This can be done a couple of different ways. Sometimes it's done by a medical assistant bringing a patient into the room and getting that information and plugging it into the electronic health record. Sometimes it's done by having the patients fill out a health history form, and then that either gets keyed in to the medical record or goes in their paper chart and is reviewed by the provider. Again, showing consideration for patients' time. They do expect to see the providers when you tell them their appointment time is. So again, we should always try to be as accommodating as we can. If it means putting them in the exam room, 5 minutes early so that as soon as the provider's done with that other patient, that one is ready to go, versus waiting until he's done with that patient and then bringing them back, we may cause a little delay there. Again, it strictly is going to depend on your provider preference. A solo or small practice should seldom have more than 5 people in the waiting room at a time. So if you only have one physician in the office, if you have 5 or more people actually waiting for appointments, you're running behind or your scheduling system is not working. You may also see patients with special needs. We need to make sure we can accommodate for that. Somebody with a concussion, for example, excuse me, may feel more comfortable lying down. So we may need to see if we can get them in an exam room. Somebody with a migraine wants to be in a dark room. They may not want to be out in the waiting room. Or somebody who is, they have special needs. They're in a wheelchair, whatever it happens to be. We try to be as accommodating as we can. Escorting and instructing the patients. So again, if they come in by themselves, we bring them down to the exam room. We don't say, go down to room 4, first door on the right. We bring them down. If they have family with them, then depending on the amount of family that they have with them, sometimes your exam rooms may only be big enough for the patient, the physician, and maybe one family member. And God forbid, if you're in an oncology office with a bad diagnosis of some sort of cancer, and you've got 5 family members that come with the patient because they want to know what's going on, you may not be able to accommodate and bring all of those family members back. So at that point, the patient should decide which family member will be going back with them, and then that family member can relay to the others. But by no means should you feel that you have to accommodate all of them. Again, health records never left in the exam room to be picked up or read by the patient. Sometimes there'll be file folders on the door of the examination room, and the health record can be placed in that holder. It's placed horizontally so the patients cannot read any information on that chart about patient name or anything like that. If the exam rooms have electronic health record, then they're logged out of before the nurse or the MA leaves the room. Nothing should be up on that screen pertinent to patient information that anybody can see once the provider or the medical assistant or the nurse has left the room. Sometimes we're going to have some challenging situations with talkative patients. Again, if you have a patient that likes to chat with your provider, we can flag ours and say patient needs a 30-minute appointment instead of a 15-minute appointment. But we can also know when we check them into the room, if that appointment has gone over 30 minutes, then you could either knock on the door, interrupt the doctor, or again, if they have pagers or a phone in that room, you can use either one of those methods to let them know that they need to wrap it up, so to speak. If children come in with parents, sometimes, they're going to be fussy and cranky. So that can be a management challenge. The parents are responsible for the children. So if the children are hopping around the chairs and standing on them and, the parents are just not doing anything, then you can bring it to management and the manager can go out and decide what they would do. And at that point, it could be the appointment gets rescheduled until they can come in by themselves. But again, the parents are responsible for their child's behavior. We're going to have angry patients sometimes. When people don't feel good, they're angry. So we want to let the patient talk out the anger. We don't always want it to be in the waiting room in front of everybody else. So maybe we can pull them in to another room and let them vent, voice their concerns, and then we deal with that in hopes to avoid any further situations down the road. Again, the patient's relatives and friends, the same type of thing. Limit, sometimes they're going to bring everybody, but due to the size of the room, you may have your provider put something in your policy manual, one family member per room or something along that line. The friendly farewell, so once the appointment's done, we'll see you next week or we'll see you at your next visit. Just be polite. Again, if we're scheduling them for another appointment, when they check out, let's give them an option, give them a couple different appointment times. And then at the end of the day, when all of our patients have gone, now is the time that we need to start planning for the next day. So this is why a lot of practices won't schedule their last patients all the way up through 5 o'clock. They may end at 4 o'clock. So by the time the last patient leaves, the staff actually has time to do what they need to prepare the charts for tomorrow. Because again, we don't want to come in the next day and be unprepared. We want to have everything ready for the provider. So in closing comments, we have, as a medical assistant, we have a huge effect on the efficiency of the healthcare facility. Friendly, helpful attitude, interactions with the patients. We want to make sure we do our best to make them feel comfortable. Providing patients with educational information booklets, not only about your healthcare facility, but if you are scheduling some sort of test for them, maybe we have something about that test and the preparation that's involved, or maybe we can get something online for them. Educating the patient about the facility's policies, so about paying the copays up front, the no-show policy, anything like that. The legal and ethical issues, again, the appointment schedule may be used as a legal record, can be brought by subpoena to the court of law. So again, making sure it is legible and that the information routinely collected for each entry. So one person doesn't just say Mary Smith and 5 other people have their names, their dates of birth, and phone numbers. Everybody needs to be the same. Do not fail to note a no-show, both in the scheduling and in the patient record. Again, that helps the provider prove that the patient did not follow medical advice. And as a medical assistant, we never offer medical advice to a patient. That's up to the provider. We can, if the provider asks us to obtain pamphlets and information, we can get that for the patients, but we never offer medical advice. Always listen carefully to your patients if they have a concern or a complaint and try to resolve the problem. Hopefully it will work and you won't need to take it further with upper management or anything like that. So that is scheduling appointments and patient processing. So if I remember correctly, we also are doing chapter 11. So I'm going to get rolling right into chapter 11. I know the billing, the insurance person comes in for 7 o'clock, so we'll try to get as far as we can in chapter 11. If not, we'll pick it up the week after Thanksgiving. So as far as the medical office environment, opening the healthcare facility, there may be certain people that have keys to open up the practice. Not everybody in the building is going to have keys to open the practice. The fewer the people that have keys, the less there is that can go wrong. Or if something does go wrong, it's easier to narrow down what might have happened or who might have done it if we have limited number of people with access. So if you're going to be the first one there in the morning, then you may be the one that is responsible for unlocking the doors and preparing the department or the office, meaning the lights are on, the waiting room is clean, the exam rooms should be stocked, anything like that. If you use an answering service, typically the messages should be obtained from the answering service. Some answering services require that you call and they give you the messages. Others will actually fax you the messages at a certain time every morning. Either way, they should be addressed and given to the appropriate people, especially if they are messages canceling appointments or stating that they're going to be late. Making sure you copy the schedules, keeping one for the chart preparation and putting one on the provider's desk so that they know who they are going to be seeing. Some providers may want you to turn on their computer to make sure it's up and running when they come in. Others have their own login and password and they will do that themselves. Preparing the reception area. So again, making sure the magazines aren't all ripped up. Disinfecting, especially if we have people in the waiting room the day before that may have been sick. You may or may not have a radio system that plays music throughout. So they call it white music, but not rap or any of that heavy stuff. Medical assistants must also prepare the patient exam rooms. Again, turning on the lights, making sure all the supplies are stacked, the rooms are cleaned, neat, orderly. If there are going to be patients in wheelchairs, making sure that you've got room for those wheelchairs to get in there. If your physician e-prescribes, then there should be no need for a pad in the room. The pads can be kept out with the medical assistant, and if the provider needs to write a prescription, you can give it to them at that time. We don't want our prescription pads in a room where patients have access to them because they could forge the doctor's name and write prescriptions for pain medicines or anything like that. So don't give them the option to do that. Supply cabinet should be unlocked except for the narcotic cabinet. Those should be locked up at all times. Quality control on lab equipment. So if you have a piece of lab equipment that needs to warm up and do certain things in the morning, you want to make sure that's ready to go before the first patient comes in and you need to have access to that. On page 178, again, they show you an example of a prescription pad, as well as a crash cart. Most offices will have a crash cart, and it's our responsibility to make sure that the supplies that we would need, should we need it, are on there and they're not expired. Everything's up to date. And closing the healthcare facility. So at the end of the day, we do kind of the same thing. Turn off the computers, the photocopier, any other office equipment. Maybe you have to physically switch your phones over to the answering service. Clean up the reception area, disinfect if needed, check the exam rooms, the treatment rooms, restock the rooms if needed. Patient-related documents should be put away. Computers should be shut down. If you've used equipment for certain procedures, they should be sanitized or disinfected, sterilized. And then, of course, lock up the medicine cabinets, lights. Some offices may have alarms that need to be activated. Again, this is going to depend on whether or not that's your job or whether it is the practice manager because they stay late after hours to finish up or to handle things, whatever it happens to do. Medical facilities typically will have cleaning staff. So we may have to do some light, picking up the exam room and stuff like that. But they're going to hire staff that would come in and clean the carpets, vacuum, wash the carpets, clean the bathrooms, that type of thing. Again, being responsible for cleaning and organize the reception area, the exam rooms, checking medications for expiration dates. Those should be checked monthly. Crash carts, again, inventoried monthly to make sure that everything on there is ready, workable, and nothing has expired. Security in the healthcare facility. Anybody in your office needs to stay alert for suspicious people. If you do have a person in your facility that you are questioning, you want to keep yourself at a distance from that person. Make other people aware in your office about that person so that they can observe as well, whether that's the practice manager, whether it's an actual security. A lot of the hospitals, if you have an office in their medical buildings, they actually have security. You could bring that in. All offices, again, you have patients that may want to steal your petty cash, medications if they think you get sample medications, prescription pads, narcotics, anything like that. So if you get a feeling about somebody that you feel is suspicious, if you bring them in the room, stay close to the door. Don't go put yourself in the corner. Again, make sure somebody else is aware. Keep the door open when you are rooming that patient. Have procedures in place for dealing with suspicious people or potential robberies. Again, many facilities have moved to locking employee entrance doors during business hours, and they require either a key card or unique code to enter the building. That way, nobody can come in other than those that have access. After hours, utilize alarms. Again, not everybody may have a facility with alarms, but at least if you do and an alarm is triggered, you know something is going on and you can do what you need to make yourself and your staff safe. One of the most important responsibilities is to manage, again, the equipment and supplies in the medical office. One of the big things, and I'm not going to go into a lot of detail, but with any equipment in your medical office, typically either the practice manager, maybe your attorney for your office, you are going to need to keep a list both of administrative and clinical equipment we should all, not just medical assistants, but we should all know how to operate and maintain issues with those equipment. Again, your attorney or your financial advisor is going to be the one that knows about the cost and the depreciation and everything like that. But we need to keep an inventory of when it was purchased, who it was purchased through. Maybe they want you to put the cost on there. Maybe they don't want staff to know how much they paid for it, and that's fine. Putting on there when it needs maintenance. So does this piece of equipment get monthly maintenance, every 6-month maintenance? Do you have to order toner for the copier every so many months? Anything like that we want to track. Each piece of equipment should be identified and records need to be maintained. Again, the accountant will utilize this inventory when they do the taxes. So anything small, blood pressure cuffs, temperature, scales, anything like that typically is taken care of or addressed for the year in which it's purchased. But your bigger equipment, such as your examination tables or computers or any big items that your practice may purchase, is going to typically depreciate over 5 years. Desk, file cabinets, those typically depreciate over 7 years. So again, here's where if we keep the list of when it was purchased, then the accountant will know how many years we've had it, if it's already been totally depreciated, or if it still can be depreciated on that next year's taxes. And then once it's to the point where it needs to be refurbished or a new one purchased, they can see, did it make it that 7 years that it was to be depreciated? If it didn't, then maybe they don't want to go that same route, and they may want to purchase it a different way, lease it, or something along that line. The inventory list also helps providers and supervisors identify equipment needing to be replaced. So it can be done via spreadsheet. And again, each item should have the equipment name, manufacturer, serial number, when it was purchased, supplier, again, the cost. They may or may not want you to know. You can see an example on page 180 of a brief spreadsheet. Warranty information, possibly. Larger facilities will indicate the location. So if it's a hospital and they have, 50 printers, where is that one particular printer? Is it in the emergency room? Is it in day surgery? Anything like that. We may be responsible for monitoring equipment safety as well as function. So checking electrical cords, fire extinguishers, some equipment needs to be cleaned and maintained routinely in order to keep up the life of the machine. So again, knowing who's responsible for that and having a way to track that it was done. Also having the owner or operation manual and the warranty information in a central location. And this probably would either be with your practice manager or maybe in the front you have a file cabinet with all that information in it. The operation manuals include the cleaning information, service scheduling, troubleshooting problems, anything like that, toner and cartridge information. So again, when and how often, cost of being replaced for the toner and everything like that. Again, if you look on page 181, the logs for routine maintenance may include, again, the equipment name, serial number, where the machine is, manufacturer, when it was purchased, warranty, when it was serviced, date and time, maintenance activities performed, and then the signature of the person actually performing. And you can see there's an example of an equipment maintenance log there as well. There are standard logs out there, or you can create your own depending on the information that you want on there. Service calls and warranty. So typically when you buy a piece of equipment, there's a warranty available for a certain period of time. Sometimes it's purchased and it covers defective parts. Other times it's not purchased, but you still may get phone calls asking if you want that service agreement or if you want to extend it if you've already purchased. Again, probably not our decision to make, probably the practice manager, but at least know who those calls go to. Purchasing equipment, again, who is responsible for this? If it's equipment that the medical assistant uses the majority of the time, the physician probably is going to ask your input. Are there certain brands that you like? Are there ones that are easier to use than others? So again, you may have your input on that. Frequency and cost of repairs may be a factor. If you bought one piece of equipment and in the 4 years you've owned it, it's been repaired 3 times each year, they may not want to go with that same particular company again. May want to try something else and hope that we don't have to fix it 3 times a year. And there's always leasing of equipment, and again, that's up to the practice, and the accountant would let them know whether leasing is a better option than outright purchasing. Again, you can help your provider with updating them on different types of models, different brands, maybe ones that you've used previously and had good luck with, anything like that. Supplies also needed to run the medical office and treat patients. We want to make sure as a medical assistant we have enough supplies to treat patients. We would not want to run out of needles or cortisone if we do injections on a daily basis for our patients. Overstocking can be a financial burden. So typically making sure we have a running tally of these supplies and how often we use them and when we need to reorder them. So have an inventory management, a way to order, track inventory, and identify the quantity that we need to purchase. Medical assistant in charge of ordering and managing supplies, keep a record on each item in inventory. Can be index cards, notebook, computerized spreadsheet. Again, very similar to the equipment. Item details, size, quantity. Like with us for casting material, there's different size of casting rolls. So we need to know whether it's a 4-inch roll, a 5-inch roll, a 6-inch roll, whatever. How many are we going to reorder? So we look at how many is in a package, what's the cost, how much more it would be if we go to the next step up. Is it more cost effective to go to the next level? Excuse me. Again, it does not matter. Have a reorder point. So when that casting supply, when you get down to 6 rolls, that should be when you reorder, especially if it's order and comes the next day. If you have to order and it's going to take a week to get there, if you only have 6 rolls and you deal with a lot of people that break their bones, those 6 rolls may not make it until that next week. So knowing about how much you use and when you need to reorder. Inventory control systems, some practices use barcodes to track their inventory. Again, anything that is going to work best for you. If you look on 184, there's manual systems for identifying supplies needing to be reordered. So when the staff identifies it, they may put it in a notebook so that whoever is doing the reordering knows that that needs to be supplied. Another system includes using product identification slips. So the slips or cards attached to the product or box and then given to the person that orders. A 2-bin system, having a main bin for each item in inventory and a backup bin. So when your main bin is empty and your backup bin is used, you know you need to reorder. The medical assistant responsible for ordering performs a hand count of items in stock. And again, this is going to depend on how much stock you have to keep track of. Some of it is easy to manually count and others may not. Again, taking inventory, pretty straightforward. Use a supply inventory list. When you take inventory, do it in a systematic manner. So if you're in a closet, start from the top and work to the bottom, or start from the bottom and work to the top. Start from the left and work to the right, and have a way to mark if you have to stop where you stopped, so that when you are able to go back, you know where you need to pick up. Again, I mentioned briefly the price consideration for ordering supplies. So if it's 1 to 5, $1.50 per item. But if you order 6 to 15, it's $1.25. So you save 25 cents on each item. But if you're going to use them and they're not going to expire, it may be better to double up on that order and save that extra $2 or whatever it happens to be. Some bigger facilities can order or join group purchasing organizations, which allow you to order from different medical facilities, so therefore you can get bigger discounts. Again, ordering supplies, you may have one vendor that you use for medical supplies and one vendor that you use for office supplies. Keep track of your accounts before ordering products. You typically can set them up right online and order. But the less companies you order from, the easier it is to track and deal with one specific company. Narcotics require special tracking documentation and a higher level of authorization when purchasing. So that may need to be done directly by a nurse or a PA or a nurse practitioner in your office. May not be able to be done by us. Some facilities use purchase orders. Again, it's going to depend on your practice. If you do use purchase order numbers, it's a form you fill out, the order number is on there, you provide that when you're ordering. Payment items can also vary. Credit cards, check, money order. Some of them you can buy and then you have 30 to 60 days to pay once you get the equipment. So again, knowing what your practice uses and how often you're going to have to pay that back, because again, you don't want to order every month if you're not using it to pay it back. Keep a copy of the vendor's order sheet. Anything that you either phone in, mail, or fax, you want to make sure you keep a copy so that you can track it. When you get the order, pretty straightforward. Comes mail, UPS, FedEx, something like that. The delivery needs to be checked as soon as possible, because if you are ordering medication, for example, it may need to be refrigerated. So we need to check it, make sure we've received all the supplies, check your packing list, see if there's anything back ordered. If it's back ordered, we highlight ours in one color so we know. We highlight it in another color if we've received it. If the whole packing list is one color and we've received everything, then we know we can file that away and that order is complete. If we are missing something, then we keep it out so that we can follow up, so that if we don't have it by the date they said it was back ordered to, we can either follow up with them and see what's going on, or if we need to, we can place an order with another company. Once you've reviewed the supplies, again, attach the packing slip to the copy of the order, put the stuff away, and you're done with it. Accounts payable folder is typically where that would go. Ours goes to our practice manager. So once we check it, make sure everything's there, we put it out in his bin in the front office and he takes it from there. Again, put things away as soon as possible. New stock should always go in the back, so that your older stock is moved forward and you use the older stuff first. So first in, first out is what a lot of people will do. So again, place your new stuff in behind your old stuff. Handling mail may or may not be your responsibility, depending on the medical practice. Some places have mail machines. Others actually purchase stamps, and you have a scale, you weigh them, you put the postage on, and then they're taken to the post office. Priority mail is a possibility, and you can look up online if you have priority mail to see what the cost is, and obtain the shipping information. Media mail has a book rate, so you want to make sure if you are sending that, you know what that book rate is. You don't want to put extra postage on things. Insurance and additional services. Again, depending on what you are sending, you may want to insure it. If you're sending a patient a piece of equipment, possibly, because they live too far to come in and pick it up, you may want to do that. If you look at the bottom, the certified mail, this typically is done for termination letters. So when your provider is going to do a letter to a patient stating they are no longer going to see them, it does require a certified mail return receipt requested. So that way we can prove that the patient got the letter stating we were no longer going to take care of that patient, and that we would take care of them for 30 days until they found another provider or whatever it happens to be. By then getting that, you have proof that you discharged, and if something happens medically to that patient, we're not liable because they have signed that termination letter. On page 190, private delivery services. So again, UPS, FedEx, maybe for lab testing, special documents, anything like that. Mail courier systems. Your incoming mail may go to a post office, or you may have a collections mailbox outside. If it comes personal and confidential, whoever is taking care of the mail, personal and confidential goes directly to the person it is addressed to. It does not mean we can open it. Professional journals or continuing education should go to the provider or the person whose name is on there. Lab test, x-rays should go to the provider ordering so that they can sign off. Magazines for the reception area. If they've been authorized, then you can put them in the waiting room. You may get some that are not authorized, and then those should go through the proper channels. Payments, going to the billing department. When your provider is on vacation, have a practice or a procedure in place for handling the mail. We want to make sure things still get addressed while they are gone. We don't want to leave things undone. We'll finish off real quick with body mechanics. OSHA, Occupational Safety and Health Act. One of the biggest things is back injuries when you are dealing with stocking and that type of thing, inventory. Back injuries are one of the most common injuries. Reaching, twisting, bending when lifting, bad body mechanics when lifting, pushing, pulling, or carrying, poor footing, poor posture. So we need to protect ourselves from bodily harm when we are lifting or carrying those boxes, if we're carrying them into storage, or if they go upstairs, or whatever it happens to be. If you look on page 192, it tells you, you've got some pictures of proper lifting with your knees bent, and non-proper bending over. And then the same thing on the bottom, carrying it close to your body versus trying to carry it way out in front of you. So again, body mechanics used by the medical assistant. needs to also be used in everyday life. We want to prevent all injuries, but specifically back injuries, if we are dealing with lifting and supplies and everything like that. The legal and ethical, again, we help protect the medical practice from lawsuits. So again, when we're using certified mail for what is being sent, we need to ensure all required paperwork is added to the health record. So again, we need to keep all that so we can prove, again, that the patient did receive it, that they signed for it, and they're aware. Without evidence that the letter was sent or received, we could get into a big lawsuit, which we probably would lose. So again, that is it for daily operations in the ambulatory care center. So again, next week for the medical assistant, we will not have class because of Thanksgiving, so you will have the week off. Again, as you are doing work, please don't hesitate to shoot messages, call, leave me messages, ask questions. I am around over Thanksgiving, so I will get back to you as promptly as I can. So if you're all set there, we'll go ahead and go into the insurance handbook. And your syllabus said Chapter 7, but I know we left off on modifiers on page 182, I believe. So I'm going to start there and go through the modifiers, and then we will go into Chapter 7. And again, I don't see anybody that's logged in, so I'm just going to keep right on going, and that way, if we finish early, we finish early. All right, so code modifiers. CPT has 2-digit add-on modifiers that allow the physician to put it on the CPT code for further definition. It may be to state what finger and toe it is. It may be to state that something unusual was done. A service was performed by more than one physician, more than one location, increased or reduced, provided more than once, only part of the service, adjunct service, bilateral, or unusual events. So the correct use of common CPT codes. So if you look on page 183, we're going to start going down through, and I will give you a brief explanation of the use of each modifier. If you look in your textbook, starting on page 189, there is also a table of the CPT modifiers and descriptions in there. So that may be a little easier to reference, and that goes all the way up through page 202. So again, if you want to look at the grid, you can do that, but I will go over in short detail what each modifier means. Modifier 22 is increased procedural service. So this is used if a physician who normally does a procedure that might take only 45 minutes due to the patient's anatomy, extenuating circumstances, may take 2 hours. If it is documented in the operative note or the note as to why it took longer than usual, increased procedural service, we can add that modifier 22 on the CPT code, and what it does is it means that if the insurance company reads the note and feels that yes, it was above and beyond, they may pay a little bit extra for that procedure code. Will they always? No. But if we get 5 out of 6 insurance companies that are going to pay us extra every time that this happens, it's going to add up. Modifier 25, significant, separately identifiable evaluation and management service. What this code is when you come into the office, if you are seen and at the time of the visit, it is warranted that you have an injection or something done in the office, this modifier 25 goes on the office CPT code, and it will allow the provider to get paid for the office visit as well as the injection or whatever he did in the office. If this modifier is not put on the office visit, what is going to happen is the insurance company is going to look at the charge of the office visit. Let's say it was $100, and let's say the injection that the patient has was $200. They're going to pay you the cheaper of the two, and they're not going to pay you anything on the other one. So by using that modifier, you are going to get paid for both. So again, we don't want to short our physicians. We want to use the modifiers appropriately and get them their reimbursement. Modifier 26. Is a professional component. So when we talk about, for example, EKGs or x-rays, for example, there's a professional and a technical component. The professional component is the doctor who actually reads the test result or the x-ray. The technical component is the billable part of who owns the equipment. So when you go into the hospital for an x-ray, the hospital bills you the technical component, and the radiologist who reads the x-ray bills you the professional component. So you're getting two charges for the same CPT code, one for the equipment and one for the provider reading it. If the test is done in your office and you own the equipment and you read the x-ray, you're only going to bill the code once. No modifier. But you will get paid the professional component and the technical component. So typically, if I'm remembering correctly, I want to say the technical component reimburses at 60% and the professional component reimburses at 40%. So if you only do a portion, you should only get paid a portion. If you do the whole thing, you will get paid the whole thing. Modifier 51, multiple procedures. If services are performed on the same day or at the same surgical session by the same physician, the operative report clearly states what procedures were done through separate incisions and what were done through the same incision. So modifier 51 can be used on multiple surgical procedures performed at same session, same provider, multiple related surgical procedures performed same session, same provider. Page 184, surgical procedures performed in combination, same session, whether through the same incision or a different anatomy, and a combination of medical and surgical procedures done at the same session by the same provider. So sometimes a physician's going to do more than one procedure at the same time. This modifier may be applicable. And what ends up happening is the third-party payers on the primary code will pay 100% of the allowable. For the second code with the modifier 51, they're going to pay you 50% of the allowable. And on the third code, 25%. And the fourth code, 10%. So you're not going to get 100% on each procedure. You did more than one at the same time. So you will get paid accordingly. Modifier 52, reduced services. This says under certain circumstances, the procedure partially was reduced or eliminated at the physician's discretion. And an explanation should be given why it was reduced. So, for example, some of your x-rays may be 3-view x-rays, but your provider only took 2 views. This would be an instance where we would put this modifier on the x-ray code, and they would reduce our reimbursement because we did not do the complete thing. Modifier 57, decision for surgery. This is one where if your patient comes into the office, talks to the doctor, they've been having knee pain, they had x-rays out of state, the doctor looks at the x-rays, says, well, looks to me like you have a meniscal tear. This is what I would recommend. Give them the options, physical therapy, maybe depending on the extent of the tear, surgery, and the patient decides for surgery. When we bill that office visit, we're going to use this modifier 57 on the office visit. Because what it does is it tells the insurance company at the time that patient presented for the office visit, we did not know we were going to schedule surgery. But by putting this modifier on it, if we schedule surgery, then we will not only get paid for the office visit, but we will get paid for the surgery as well. If we don't use this modifier and we see him today, let's say for a fracture, and we do surgery on him Friday, we're not going to get paid for the surgery on Friday because we did not use a modifier, and they're not going to pay for an office visit within so many days of a procedure. So 57, decision for surgery. Modifier 58, staged or related. It indicates the performance of a procedure during the postoperative period was as follows. Planned or staged at the time of the original service, more extensive than the original procedure, for therapy after a surgical procedure. So those are some instances where we can use that 58 modifier, and not only will we get paid for the initial surgery, but we will get paid for the one that we had to take the patient back and do more surgery on. Without that, they're within the global period, and if we bill the same CPT code, we are not going to get paid at all. Modifiers 62, 66, 80, 81, and 82, more than one surgeon. 62 is co-surgeons, so it's two surgeons working together to do distinct parts of a procedure. Each physician has to report their own documentation of what they did. Modifier 66 is a surgery team, so a group of doctors working together. 80, assistant at surgery, when the surgery is not performed at a teaching hospital. 81, minimal assist. And 82, assistant surgeon used for surgeries done in a teaching hospital when a qualified resident is not available. And if you look down below, that modifier 80 is commonly used when a physician assists the primary physician in that surgical procedure. The assisting doctor is paid only 16 to 30%, and then the regular surgeon gets paid the rest. So the assist is not going to make what the regular surgeon makes. Then we have modifier 99. So sometimes we may do a procedure that requires more than one modifier. If that is the case, we can do one of two things. We can use the modifier 99 to say we need to use more than one modifier, or we could actually list the modifiers. And when we do the next chapter on the insurance claim form, I will show you where those modifiers get listed on the claim form. In the too many years, 20, 30 something years, have never had to use the 99 modifier. I have always been able to use individual or a couple modifiers to describe what my physician is doing. If you look on 188, we also have what we call Health Care Common Procedural Coding System modifiers, or HCPC modifiers. These are typically alphanumeric or 2 digits. You use them when they're necessary. And again, if you look at the bottom of page 188, for example, the HCPC modifiers refer to fingers, toes, eyes, eyelids, There's some anesthesia modifiers in there. But when we deal with fractures of the fingers, we need to let them know what digit was fractured. So we will use FA if it's a thumb fracture or whatever it happens to be. Again, you can look at table 6.6, starting on 189, going all the way to 202, and this goes through, again, each of the modifier, goes into a little bit more in depth of when you can use it, when it's necessary, and it would give you an example. Now, I know I gave a couple examples on some of them. Again, this goes into a little bit more detail about the modifiers. If you look on, page 206, this is a part of a claim form. And if you look after the D column, you will see a modifier column with 4 individual blocks. That is for the modifiers. So if you are going to use more than 4 modifiers on any one CPT code, then you would use that modifier 99. Otherwise, you have the availability to use 4 modifiers for every CPT code that you bill. You will also see on the next page, it has a, on both pages actually, it gives you a diagnosis pointer for the diagnosis code that goes along with that particular CPT code, a charged amount, how many units we did. So some procedure codes are billable by each individual unit or each finger, and others are how many fingers did we do. So some of the units may be more than 1. But that is the modifier, giving you a brief history of what the modifiers are and how they are used. Excuse me. So now what we're going to do is Chapter 7. We're going to talk about the paper claim, or what's called the CMS 1500. We're going to talk about when paper claims are used, the history of the claim form, 2 types of claim submission, talk about clean, pending, rejected, incomplete, invalid claims. If you take a look on page 210, you will see the CMS 1500 is the standardized paper claim form. It's used by professionals and offices to bill insurance carriers for services that they provide. Over the years, that claim form has gone through numerous changes. It first started out as the CMS 1500, switched to HCFA 1500. Sometimes we can still submit paper claims, and other times we need to submit what's called electronic claim submission. With Medicare, if you look in that second paragraph under the paper claims, Medicare requires that we send claims to Medicare electronically, which started in October 16th of 2003. There are a few exceptions to which paper can be sent for Medicare, but otherwise, if you do not submit your claims electronically, you will not get paid. The paper claim continues to be an important part of the claim process. There are exceptions for which providers are not required to send claims to Medicare electronically. It would be if you are considered a small provider or supplier with fewer than 25 full-time equivalent employees, or a physician, practitioner, facility, or supplier with fewer than 10 full-time employees. So if you fall into those categories, you can still submit your claims via paper. ASCA also allows an exception to any healthcare provider who may be in an area that has disruptions in electricity. That could be more than 2 days. They can submit to paper. So, for example, with the power outage, for some offices, if they were going to be without power for, let's say, 10 to 14 days, it is possible that Medicare would allow them during that time period to send their claims via paper because they had no other way to submit them. ASCA does not preclude providers from submitting paper claims to other health care payers. There may be occasions where the practice's software has technical downtime and you can't submit electronically. Paper claims often are used when reporting special services because you have to send records. Paper claims are used when resubmitting a claim for follow-up after the original denial, because we're typically going to fill out an appeal or a redetermination form and send records. Paper claims can be provided to patients who have coverage with other insurance to which we do not participate, and then they can submit them to that insurance carrier. And the paper claim can also be used to report patients' encounter to federal, state, and other health agencies. So again, the paper claim is called the existing CMS 1500 claim form, and we will see what that looks like in a few minutes. It was developed by the National Uniform Claim Committee, as well as the American Medical Association and the Centers for Medicare and Medicaid. And it's made up by people who have an investment in getting claims paid and what these claim forms need to have for information in order to get them processed. NUCC, the National Uniform Claim Committee, was formally named an administrator simplification of the HIPAA. So as HIPAA came about, years ago when we would fill out claim forms, everything needed to be in its own separate place for different insurance carriers. With HIPAA, that has changed. They have made it more uniform for submitting claim forms, which means it's easier for us all the way around. The paper claim goes back as far as 1958, when the AMA attempted to standardize the insurance claim form. Again, there's been few changes here and there on the claim form. And you can see up on page 211, starting in 1958, 1975, there was a universal claim form called HCFA 1500, or Healthcare Financing Administration. 1990, it was revised, printed in red ink for optimal scanning. Mid-1990s, it was replaced by National Uniform Claim Committee. 2001, the HCFA now is known as CMS 1500. 2005, it needed to be able to accommodate the national provider number, which came into play because of HIPAA. 2009, needed to accommodate electronic claim submission, or version 5010. If you were not 5010 compliant, you could not submit claim forms. 2012, the revised edition of the HCFA 1500, or the CMS 1500 for ICD-10. January 2014, support vendors required to handle and accept the newly revised form. And then April of 2014, the 1500 claim form was discontinued and only the revised 0212 version was accepted. So if you use the old version, your claims would also be denied. The claim forms, if you are submitting by paper, can be purchased through local vendors, local companies, any medical office supply. The American Medical Association sells them as well. Again, needs to have the red ink. If you submit electronically, everything is set up in your practice management system according to the claim form. So when you input that data, it goes on the claim form where it needs to be, and when it gets to the insurance company, it prints out how the insurance company needs it to process. So again, the paper claim submitted on paper, it is converted to electronic form by insurance companies. A lot of people hand wrote the paper claims, some typed them, depends if they were legible or not. Electronic claims submitted to the insurance carrier via dial-up modem, direct data entry over the internet, file transfer. There's a lot of different ways. Some of the insurance companies, you can actually, if you don't see too many patients with that insurance, you can actually key those claims directly in on their website. Again, depends on the numbers. Excuse me. Paper or electronic can be designated as clean, rejected, or pending. A clean claim means the claim was submitted within the timely filing limit. It has all the information to be processed and paid. A physically clean claim is one that has no staples or highlighted areas on which the barcode area has not been deformed. A rejected claim means the claim has not processed or that it cannot process for various reasons. Maybe they can't find the patient in the payer file. Maybe the date of birth is wrong. A lot of different reasons why it can be rejected claim. A pending claim is held in suspense for review by the third-party payer, and the amount of time that it's held varies. Some may take only additional 9 to 10 days to process, depending on what they need for information, and others can take longer. Sometimes a pending claim is looking for medical records, and if they send you a request for medical records and you don't reply to it promptly, it's going to take longer than that 7 to 10 days because they're waiting on that information from you. According to Medicare, again, a clean claim means it has no deficiencies. It passes all electronic edits. The carrier doesn't need to investigate outside the carrier's operation before paying the claim. The claim is investigated on a post-payment basis, meaning the claim is not delayed before payment. It's paid, and then after it's paid, if they review the claim, you may get a refund request if they realize they've processed it incorrectly. The claim is subject to medical review with attached information. Medicare claims are considered clean claims, which require, Medicare claims not considered clean claims require investigation on a pre-payment basis, are known as other claims. If you are a participating provider and you submit your claims electronically, typically you're going to get paid within 14 days of receipt. If you are participating and you provide paper submission, or you're non-participating and submit to paper, it's 27 days or longer. So it does benefit if you can submit them electronically. An incomplete claim is a Medicare claim missing required information. Invalid claim contains complete necessary information but is illogical or incorrect. So an incorrect provider number for a referring physician, for example. A dirty claim submitted with errors, so it requires manual processing for resolving the problem, or it's rejected for payment. A deleted claim is a claim canceled, deleted, or voided by Medicare. Maybe your itemized charges were not provided. There were more than 6 line items on the claim form. Patient's address is missing. Certificate of medical necessity for durable medical equipment was not attached. There's a whole variety of reasons why they will just delete the claim. The Omnibus Budget Reconciliation Act requires Medicare contractors to pay prompt payment interest rate on a clean claim if it is not paid in a timely manner. So if for some reason the claim is clean, but it doesn't get processed for payment, when it finally does, Medicare has to pay you interest on it. And the interest rate is updated January 1st and July 1st through the Treasury. Sometimes we're going to need to abstract from the medical information, medical records to help support our documentation, our diagnosis codes, our CPT codes. When requesting a review for a denied claim, the insurance billing specialist is required to send a cover letter with the claim and the information that needs to be addressed. That cover letter should also have the patient name, address, insurance information. Most of the insurance companies actually have a redetermination form, so you may not necessarily have to do a cover letter. You may need to fill out a form and then submit it to the insurance carrier. But you can see up on 213 an example of a chart note. So block 24A is where the date would go, the date of service. 24D is where our CPT code goes. So if you look at the claim form, the CPT code is 59410. If you look up above and read the description, it says it is a patient having labor pains admitted to College Hospital on 2/10, healthy, 6-pound, 4-ounce baby girl delivered vaginally. So that 59410 code is the delivery code for that baby. Block 14, date of last menstrual period. If she's got additional diagnoses, we would find it in the notes. The dates that she was hospitalized, dates of disability. All of this information, if you look down below, is all on these claim forms. So as much information as we have that we can give the insurance company, hopefully it's less reason for them to deny it and kick it back to us. If you look on 214, health insurance claim form, again, the CMS 1500, the 0212 version, guidelines for submitting a claim. Claim form should be completed and submitted as required by payer rules on behalf of the patients covered by a third-party payer. In some very rare cases, your provider may not submit directly to the insurance himself, maybe because the practice is too small or the type of services that he provides. And in some cases, the patient's going to bring in a claim form that we need to provide them information for that they in turn can submit to that private insurance policy that we may not participate or submit for. When a patient has group insurance through an employer, we need to make sure we have all that information about the employer so that that goes on the claim form so there's no question about the policy or benefits. Sometimes people are going to have two insurances. It's called secondary insurance. When two insurance policies are involved, it's called dual coverage or duplication coverage. For billing purposes, the primary policy is the policy held by the patient when the patient and his or her spouse are both covered by employer-paid insurance. We always need to obtain the patient's signature for assignment of benefits, which again is on our registration form, so that they give us the okay to bill the insurance company and have the insurance company send us the payment. If your patient is insured by two companies, we need to find out which is the primary and which is the secondary. Once the primary insurance has paid the claim, if there is anything left, it needs to be submitted to the secondary insurance with the explanation of benefit from the primary, stating what they allowed, what they paid, and what is left to be paid. So the completion of the claim forms. In block 21, which you can see Nope, you can't see it on the bottom of this page. We'll see it in a minute on another claim form. These are our diagnosis codes. Diagnosis codes should never be submitted without supporting documentation in the medical record. So that just means that we don't want to give the patient a diagnosis that they don't have. On the claim form, we used to have only the availability to put 4 diagnoses. On the claim forms, we now have the availability to put 12. Big difference from 4 to 12. Specialists, maybe not so much, but primary care that treat patients with multiple illnesses or diseases, definitely. Service dates must be entered with no spaces using 6-digit or 8-digit format. So January 2, 2000, whatever. And it needs to be specific, no ditto marks, no punctuation. Some carriers allow medical services or office visits to be grouped if each visit is consecutive around the same month, uses the same procedure, or results in the same fee. So again, if this was something you were doing with your particular provider, you would want to make sure that you were billing appropriately for consecutive dates of service. Sometimes there's going to be no charge, such as a post-op visit within the 90-day global period. There is still a CPT code that lets us know it's post-op visit, but it has no dollar amount associated to it. It has a 0 charge. It will not generate a claim form, but it is used for reporting purposes. Physicians' identification numbers. They have a state license number. So in each state that they perform duties, they are going to have a state license number. Employer identification number or a tax ID number. And that's for Internal Revenue Services. Each physician obviously has their social security number. As long as they have a tax ID number for the practice, typically they will use the tax ID number instead of their individual social security number. Provider numbers, national provider identification, 1 for each physician. So referring physicians have NPIs, ordering physicians have NPIs, the doctor that performs the service has an NPI. This NPI number needs to be on the claim form in order for the physician to be paid. When a non-physician practitioner bills incident 2 in the same group, but the physician is out of the office the day they see a patient, then as long as there is another physician in that practice in the office, they can bill under that other provider. And incident 2 is a whole nother can of worms, so we don't go into it too much unless you are actually dealing with it. To assist with the claims completion, we have it is good to keep a reference list of provider numbers for each of your individual physicians. Typically their license number, their DEA number. They used to use PIN, P-I-N, or UPIN, uniquely provider identifier number. When HIPAA came about and the NPI numbers came into play, the UPINs or the PIN numbers went away. So they are no longer identified by UPIN numbers, but just be aware that that was prior to HIPAA. Each individual group practice will have their own group NPI, and then each individual physician has their own physician NPI. And again, the NPI is a lifetime 10-digit number. It replaces all other numbers, and it's assigned and retained for a lifetime as long as they practice. If they provide durable medical equipment, or DME, they will also be provided a DME number by Medicare. Without this DME number from Medicare, then they're not going to get paid by Medicare. Medicare has to authorize you to bill them for durable medical equipment. So to do that, there's forms, certain criteria, And once you are given that DME number, you can then provide the walkers and the splints and that type of thing for your patients. Each facility, such as a hospital, lab, radiology, skilled nursing, they have their own facility provider number as well. And when everybody applies for an NPI number, they have to select a taxonomy code that gives a description of the services that they provide. So for instance, ours is taxonomy for orthopedic medicine. Cardiology has a taxonomy code. It's another special identifier. Physician's signature, obviously, he does not need to sign each individual claim form, but it will say signature on file, and that allows you to put the physician's printed name on the claim form in the appropriate block as if it were normally signed, and that is an acceptable method of the physician's signature so that they can get reimbursed. If you are doing it by paper, sometimes they would require that whoever's filling out the claim form put their initials at the bottom, the right corner of the claim form, so that it could be referenced easier and they knew who filled out the claim form. That way it decreased errors and you wouldn't accuse somebody else of filling it out. Proofread. So again, if you're doing these via paper, you want to proofread, make sure you didn't transpose your numbers, your date of birth, whatever it happens to be. If you are doing it electronically, as you are keying it in, you would do pretty much the same thing. Just make sure the information in there is correct. Supporting documentation. When I went over the modifiers, I talked about a couple modifiers that I said you have to submit documentation for. That's what supporting documentation is. So if that procedure normally took 45, my doctor took 2 hours, but it was because of, the anatomy of the patient. If we sent the supporting documentation, it is possible that my provider would get paid extra for the extra time it took them to do that. If we are using a medication that's expensive, sometimes we have to send the invoice so that the insurance company knows how much we spent for it, so that they're not thinking that we're overcharging them for the medication, because they would have no way of knowing if what we were charging was within the correct ballpark. So when a procedure takes additional time, anything like that, we're going to have to send documentation. If you look on page 218, if you are submitting via paper, you should keep a copy of the insurance claim form. Most people keep them in an alphabetical tickler file. You should have a way to follow up on them every 30 days. So if you're not being paid, you can make appropriate phone calls or what have you to find out what is going on with that claim. If you submit electronically, you've already got that copy in your system. But if you are using paper, you always want to keep a copy, because otherwise you have no record that you sent it. And if you have to send it again, you're going to have to fill out another one all over again. Reasons why claim forms are delayed or rejected. So we phoned the insurance company and discovered there was no record of the claim. So again, if we did not copy that claim that we submitted via paper, we have to start from scratch all over again. So always keep copies. She's in a hurry, submits a claim form that's ineligible or illegible. Never handwrite a claim form. So you want to make sure if you do have to handwrite it, it's legible, or use a printer. Untimely or lack of response for requests for records, for example. So pay close attention to if they are asking you for information, that you get that information back within that time frame. If you do not, they will suspend the claim, which means you're going to wait even longer to get that claim processed. If you review a Medicare remit and discover a non-covered service that is deemed not medically necessary, you would need to check the local coverage determination and national determination for diagnosis requirements. It may be something as simple as reviewing the patient record, and there may be a diagnosis code in there that supports medical necessity. It's just your doctor didn't give it to you. And we may be able to get that claim paid. Don't ever take a denial as, okay, they're not going to pay it and don't do anything about it. Always question a denial. Research it, try to get it addressed. Non-covered service occurs because a routine screening is done in conjunction with a routine exam. So we need to determine if it's diagnostic or preventative, if we use the correct code. Maybe we didn't put a modifier on it. Payment adjusted because another insurance is supposed to pay as primary and Medicare, for instance, is secondary. So we should always check patient's coverage, verify eligibility. Global. So if you're billing something that's during the global period, is it something that we can correctly use a modifier on to get reimbursed, or is it something that we're not going to get reimbursed for and we shouldn't have billed it? So make sure we know the global periods. Submitting a claim with missing or invalid information. We want to make sure we have everything. Remits if we're submitting excuse me, to secondary insurances. Now, if you look on page 219, this is just a table that tells you in these certain boxes or blocks what might be missing and what we would do to fix it. So for 1A, for example, the patient's insurance number incorrect or transposed. So we need to proofread the numbers, photocopy front and back of the insurance card, and that way we make sure that we have the correct information. If you look on 221, the OCR, or the optimal character recognition, if you look, this is the red is what can be optimally scanned. So there's more control over something that's being optimally scanned. It improves accuracy, reduces coding errors, and it clearly is easier for the insurance companies to process. So some do's and don'ts for claim completion. Use original claim forms printed in red ink, no photocopies. Do use computer-generated or type all information in black. Don't handwrite. Do make sure the printer is aligned correctly. If it's not aligned correctly and something is typed on the red line, that's enough for the claim to be denied. Don't allow characters to touch the line. Don't use script, slant, italicized fonts. Keep characters within the borders. Do not strike over any errors. Do complete a new claim form for additional services if you have more than 6 line items. Do not use a highlighter or colored ink on the claim. Do not use decimals or dollar signs in block 21. Do not use narrative descriptions of the procedures, modifiers, or diagnosis codes. That's why they have numbers. That is sufficient. We do not need descriptives. Do not use not applicable or DNA when information is not applicable. Leave it blank. Do not use paper clips, tape, stickers, staples. Do enter 6 or 8-digit formats. Do keep signatures within the signature block. Keep the claim form clean, no stains, no glue, no scribbles. Do not fold or spindle forms when you're mailing, so it goes in a big manila envelope, no folding. And do not send claim attachments smaller than 8.5 by 11. They're easy to get separated and lost. So it should be the same size as the claim form. So this next section goes over the individual claim form. I'm going to go through it briefly. If you are going to be working in a facility or a doctor's office where you would be filling out claims via paper, then this would be a good tool for what boxes need information. If you are sending claims electronically in your practice management system, whatever is needed on the claim form to be submitted, your practice management system is going to ask for. So as long as you're keying that information in, it is going to go on the claim form where it needs to be. And again, with HIPAA and the standardized forms, we don't need to put individual information for TRICARE and individual information for Anthem. It's all the same information on the claim forms. So if you look on 223, there's a little barcode thing, not barcode, but a little block up at the top, carrier block. And then we have underneath it, block or box 1, ask if it's Medicare, Medicaid, TRICARE, CHAMPA, group health plan, FECA, or other. So again, depending on what you put in the patient's account for insurance information, it will check that box off. 1A is the insured ID number. Without that, you're not going to get paid. Patient's name, last, first, middle initial if you have it, date of birth, sex, and then insured's name. So the insured's name would be the same as the patient if they are the policyholder. But if you're a child and you're under your dad's insurance, then the patient would be the child and the insured name would be the dad, for example. Look on page 224. So again, the insurance information, the insurance ID number. You will see down below for the insurance ID number for TRICARE, it's the sponsor's social security number or a special VA number. Same thing for CHAMPA. For workers' comp, it's actually a claim number. For property and casualty claims, it's the federal tax ID number. Down on 225, I already went over it, but the patient's date of birth and the sex. And then block 4 is the insured's name, so the person who holds the policy. On page 226, if it's a workers' comp claim, it would be the name of the employer. If it's a property and casualty claim, it's the name of the insured. Block 5 is the patient's address, so permanent place of residence, no temporary addresses. And again, down below, it just tells you if it's an AFO or an APO, military, overseas, it tells you to use the actual place of residence, not the APO address. Block 6, patient relationship to insured. So is it the patient, spouse, child, or other? Insured address, again. On page 228, block 8 is reserved for NUCC use. So if this was applicable, you would be given the information that needs to go in that field. Block 9, other, insured's name, and it does not have to be filled out. If there's not an other insured's name, it is left blank. Block 9A, other insured's policy number. So again, you can leave it blank. If there's nothing to be inserted there, it's fine. Block 9B, again, also reserved for NUCC. 9C, 9D is the insurance plan name or program name. Block 10A to 10C is the condition related to employment, auto accident, or other accident. If one of these is checked and you submit it to their regular health insurance, they may not pay it because you've checked one of those boxes saying somebody else may be liable. And this would be an instance when they would verify if it's workers' comp, auto, whatever it happens to be. 230, Block 10B, again, this is used by NUCC, so you may or may not ever put anything in there. Block 11, Insured Policy Group or FECA number. Block 11A, Insured's date of birth and sex. 11B is another one for NUCC if there is another claim ID number. 11C, insurance plan name or program name. 11D, is there another health plan? Because they want to find out if there is, they want to see if they should be paying first or if the other plan should be paying first. Block 12, the patient is not actually going to sign there. It is going to say signature on file. And that demographic form that you have them fill out in the office with their address and phone number and social and all that, at the bottom, it gives your office permission to bill the insurance. That is where the signature is. So on the claim form, all that it's populated with is signature on file. Block 13, insured or authorized person signature, same thing, would say signature on file or SOF. If you don't have their signature on file, you can put no signature on file, but the insurance company is probably going to send the check to the patient, and then you need to track it down. Block 14, date of current illness, injury, or last menstrual period. And again, 6-digit or 8-digit. Other date identifies additional information about the patient's condition. So you can see down below the initial treatment, acute manifestation, accident, first visitor consult. Again, may or may not be applicable depending on the specialty. Block 16 dates patient unable to work. So if it's surgery and they're going to be out for 4 weeks, you want to put that in there so the employer knows. And again, 6-digit or 8-digit. Block 17 is the name of referring provider or other source. So here is where if they have an insurance company that requires a referral from their primary care, if box 17 does not have the primary care physician's correct name and NPI number, you will not get paid. Or it will process as out of network, which means the patient is going to be responsible for more than just their copay. So it's important to have the correct referring physician information. Block 17A is other ID number, and again, that's the referring physician's NPI number. Or other NPI, and 17B, again, NPI number. Block 18, hospitalization dates. So if they're an inpatient, we want to put when they were admitted, when they were discharged, so they know how long we treated the patient in the hospital. Box 19 is what we call a free text box, but when you report certain things, if you need to, you can put handwritten information in that block. It allows us to put provider network ID numbers. Sometimes, depending on the carrier, they will ask for the taxonomy code in box 19. If it's a corrected claim, they want that in box 19. And if you look down below on 236, here are some different codes that we can also use for additional claim information when we are submitting the claims so that they have that information. Block 20, outside labs. So if we were billing outside labs and then what the charged amount is. Block 21, here's where we put our diagnosis codes. And again, we have the availability to put 12. Now, if you look to the far right, under the diagnosis codes, you see a column that says E diagnosis pointer. So we can use 12 diagnosis codes, but maybe for that 99203, we only want to use the first 2 diagnosis codes on this claim. So under diagnosis pointer would be A and B. Maybe the next line down is not pertinent to A and B, but it might be pertinent to H diagnosis. So whatever diagnosis is applicable to that procedure code, we use the letter of the pointer, so to speak. Box 22, resubmission or original reference number. So some of the insurance companies, if we need to resubmit claims, they will let us know what to use for a reference number in that box when we resubmit. And it lets them know it's a replacement of that old claim, or it's a cancel of that old claim, and this is the new one. Block 23, prior authorization. So if it required an authorization, this is where that authorization number is going to go. If you did surgery and did not get an authorization and there's nothing in that block, you're probably not going to get paid. Block 24, dates of service. And again, you can see we have the availability to put 6 line items. So to and from. 24B is the place of service. And the place of service is a 2-digit code. And the 2-digit code tells us where it was done. So for example, 11 is office. 22 is outpatient procedure. 21 is inpatient. So again, those are going to be all set up, but we need the place of service. 24C, if it is an emergency, we are allowed to check that box off. You can see on page 240, here's the list of the place of service codes. 24D, again, here is where your procedure codes or your CPT codes will go. So what the provider did for services for the patient. 24E is that diagnosis pointer that I just talked about, why the services were performed. 24F is the dollar amount of the charges. 24G is day or unit. So if the to and from date was 9/9 to 9/12, then you're going to have 9, 10, 11, 12. That would be 4 units if the CPT code was the same for each day. Otherwise, if it's just 9/9 to 9/9, 1 unit. Block 24H has to do with state Medicaid plan. So again, this may or may not pertain to you depending if you treat early and periodic screening, diagnosis, and treatment for main care patients. 24I, if the provider does not have an NPI number, then we need to enter an appropriate qualifier and identifying number. So if they don't have an NPI, you will see down below the identifier would be if we're using their state license number, OB, if we're using their UPIN number, 1G. Mostly everybody should have applied for a NPI number, but possibly if they're in process, new provider, you may not have it. 24J is the rendering provider ID number, so the doctor's NPI number that performed the service. If you look on page 246, block 25 is the federal tax ID number, or if you use the social security number, you would have the box SSN checked off and their social security number. 26 is the patient's account number. That's their account number in your practice management system. So if you track your patient by number, so if I was number 1 in the practice, that would be 1. If you came into the practice 5 years later and you were 1500, that would be your patient number. Do you accept assignment? Yes or no? Yes means the insurance company is sending you the check. No means that your reimbursement can be different and the check's going to the patient. 28 is total charge. 29 is amount paid. This would be in the instance of a primary insurance paying and then you're sending it to a secondary. So column 28 would have the total charge, so let's say $500. Primary insurance paid $200, so in block 29, it's going to populate how much they paid, and then the next box says revised for NUCC use. So again, we don't need to put anything in there. It used to be that we could report the balance due in that field. It's going to, again, depend on your practice management system. 31 is signature of physician or supplier with their credentials, so if they're an MD or a PA. Box 32 is the name of the facility where the services were rendered. So if it's your office address, it would be your office address. If you're doing an outpatient procedure at the hospital, it's going to be the facility address. 32A is the NPI number of that service facility. So again, if it's your office, it's your group NPI. 32B, other ID number. This would be a non-NPI number. 33, billing provider info and phone number. So the billing provider or supplier, mailing address, billing office location, telephone number. So if you were using a billing company, for example, it would be the billing company's address. If it's your office, it would still be your office address. Box 250, 33A would be the NPI, again, assigned to that billing provider, so whether it's your practice or your provider. And box 33B, again, other ID or non-NPI number. Now the next quite a few pages gives you examples of individual claim forms by payer. So if you look at 252, it's for a private payer. Overall, the information that's needed for these claims are all in your practice management system. And if that insurance company needs them on the claim, as long as you're putting them in your practice management system, it's going to put them on the claim form. But again, the patient information obviously is going to be different. NPIs can be different. Medicaid, if they do not have a primary care physician, there's not going to be anything in 17. If you look at 254, this is if a claim just went to Medicare and they have no other insurance. And then the next page, 255, is if it's Medicare and main care. And you can pretty much see that the only difference on this claim is box 9D. It gives the secondary insurance information. And it has a prior authorization number because his secondary insurance requires it. 256, Medicare and Medigap. Other insurance and Medicare. TRICARE, no other coverage. CHAMPA, no other coverage. And a workers' comp claim. What I did when I was first learning to fill out claim forms is I photocopied and I put them in a little binder so that when I had to fill them out by paper, if I had to, I knew what needed to go into what boxes. The good thing is with HIPAA, now that it's all computerized, again, as long as you are putting the referral number and the referring physician into your software, it's going to put it on the claim form where it needs to be. So that is just a quick introduction to the paper claim. Now, in your workbook, I believe you are going to have, let me just see, 7.2. Yeah, you're going to complete a claim form for a private carrier, or you may complete a claim form for Medicare. So use these samples in your book as a tool for what needs to go on that claim. Your claim forms are right on Evolve, so you can fill them out on there, or you can print them off and hand fill them out. Doesn't matter to me, whatever is easier for you. If you're working by the book, it might be easier to print a whole bunch out and then work through them. So again, no class next week because of Thanksgiving. We will resume the week after. So that would be the 29th. If over the break, again, you're working, anything comes up, questions, anything, shoot me an email, shoot me a text, leave me a voicemail, and I'll look it up and get back to you. And other than that, I think we are good to roll. So after Thanksgiving, we will go into the electronic claim and receiving payments and starting to problem solve with the insurances, some collection strategies, and then we'll talk a little bit about the individual major insurance carriers. So if there's no questions, which nobody's logged in, we will call it good, and I will see all of you the week after Thanksgiving. Everybody have a good Turkey Day and drive safe.